before Sanjay starts with his presentation, I just would like to introduce you to the GoToWebinar system. As you can see in the slides, there's one screen where you can see the slides that are being shared. And you have two ways of asking questions. So one is, obviously, if you click on question, you can put them in writing so that I will see what you have asked and that I can read the questions out loud for the speakers. Or if you wish to ask the questions yourself by speaking to the microphone, you need to click on the small hand button that you can see on your control panel. Then I can see that you have raised your hand and I can unmute you so that you can speak into the microphone. We do questions at the end of the presentation. So first we have the presentation and then we have 15 to 20 minutes for Q&A. This is basically it from my side, and Sanjay, the floor is yours.
Thank you very much, Christian. Hello, everybody. My name is Sanjay Pagani. I'm an infectious diseases consultant at the Royal Free Hospital and a senior lecturer at UCL in London. So for the next 20 minutes or so, we're going to talk about hepatitis B prevention. Next slide, please, Christian. So before we actually go into hepatitis B prevention, we just need to kind of have a brief look at the global epidemiology of hepatitis B so that we can try and understand where the biggest needs for prevention are on a global basis. So this is the most recent data from the WHO Global Hepatitis Report 2017. Looking at the bottom right-hand side in terms of prevalence, you can see that there are around 260 million people living with hepatitis B globally, and that the vast majority of the burden of this disease is in the WHO regions of Africa and the Western Pacific. The Western Pacific is the WHO region that covers China, Mongolia, Cambodia, Laos, and all the countries around there. And then there is the Southeast Asian region. And so between the Western Pacific, the Southeast Asian region, and Africa is where almost all of the burden of hepatitis B globally lies. What you can see on the top end of this slide is that as a result of immunization, the chronic hepatitis B infection in children under 5 has reduced from 4.7% down to 1.37%. And we'll talk a little bit more about this in detail, but clearly we're already starting to see some successes in terms of hepatitis B prevention. Next slide, please. So the question that we really need to ask ourselves is, why is hepatitis B such a big problem in terms of clinical disease? And I think, you know, perhaps hepatitis B's biggest contributor to morbidity and mortality is as a result of hepatocellular carcinoma. This is some really recent data looking at a global meta-analysis of the causes for liver cancer around the world. The orange bars are the contribution from hepatitis B, and as you can see, overall globally, almost a third of all liver cancers are associated with hepatitis B infection. And then if you go down to the very bottom bar, which is Western Sub-Saharan Africa, here you can see that just under half of all liver cancer burden is associated with hepatitis B infection. And so this clearly suggests that if we're going to have any impact on liver cancers and morbidity and mortality associated with liver cancers, then the thing that we really need to tackle, amongst other things, is hepatitis B. And next slide, please. So in order to understand the prevention of hepatitis B, we must understand the modes of hepatitis B transmission. So hepatitis B, like all the blood-borne viruses, is parenterally transmitted, and spread is mostly via exposure to blood and bodily fluids. In order to get transmission, one needs a break in the skin or mucous membrane. And remember that this virus is not only found in blood, but it is also found in semen. In other words, sexual transmission of hepatitis B is extremely efficient and is found in saliva, vaginal mucus, and tears, but at levels that are a lot lower than those in serum. Fortunately, the virus is not found in urine, sweat, stool, or indeed breast milk. Next slide, please. And so in order to understand immunity to hepatitis B, we just need to understand a little bit about the blood serum markers in hepatitis B infection. So those of you that were with us for the hepatitis B treatment seminar, we looked at this slide in a little bit of detail. For this particular seminar, I'm not going to talk you through all the serum markers of hepatitis B. I'm just going to point you to one which is circled, which is anti-HBs or hepatitis B S antibody, which is the protective marker of immunity against hepatitis B infection. Next slide, please. And so the major determinant of immunity is the hepatitis B S antigen and the antibody response to it. As you can see on the left-hand side of this slide, there's a diagram of the whole virion of hepatitis B, which has got a number of different proteins, including E antigen, core antigen, and surface antigen. The surface antigen also can exist in its free form without the whole virion in blood, in large and small subunits. The surface antigen, or the S protein, is not a homogeneous protein, but it has three different antigenic determinants. In other words, there are three regions of the S protein that you can raise antibodies against and neutralize. So there is the A region plus any two of D, W, Y, and R. And it is that differences between the other subunits that gives us the hepatitis B genotypes that we talked about when we talked about chronic hepatitis infection. Now, in terms of protective immunity, because the A determinant is common across all HBV genotypes, having antibodies against the A determinant gives you cross protection against all hepatitis B genotypes, and that's why the S antibody is cross-protective against all genotypes of hepatitis B. Next slide, please, Christian. And so vaccination remains the key against prevention of hepatitis B. Since the mid-80s, we've had recombinant hepatitis B S antigen vaccines, which are now standard of care in terms of global use of hepatitis B vaccines. And there are a number of commercially available preparations, as you can see on the table below, which is just a few examples of the products that are available, and they're available either as monovalent hepatitis B vaccine, in other words, just containing the S antigen, or they can be combined with hepatitis A and B, so to have the combined Hep A and B vaccine, or they can be combined with all the other vaccines that are part of the childhood immunization program, as in the hexavalent hepatitis B at the bottom of that table. Now, unfortunately, even in 2017, there is a requirement for a cold chain for these vaccines, although they can be transported at ambient temperatures. And this can raise challenges in terms of global immunization programs. Next slide, please. In terms of protective efficacy, after 3 doses of vaccines, 90% of healthy adults and more than 95% of children and adolescents develop protective antibodies. And the standard schedule for the vaccine now is 0, 1, and 6 months, so spaced out enough to be able to give you a protective S antibody response. Most countries have adopted this in their expanded program of immunizations for children, and we'll look at some data regarding this in a second. But the vaccine is between 80 to 100% effective in preventing infection, and where it doesn't prevent infection, it certainly promotes viral clearance and prevents serious clinical disease as a result of exposure to hepatitis B. Higher doses may be required in immunocompromised patients, and so double dosing schedules may be needed, for example, in HIV-infected patients or renal dialysis patients. Next slide, please. And so here are just a few studies that I wanted to bring up looking at hepatitis B vaccination in vaccination-naive adults with HIV. And I just want you to concentrate on the upper box at the moment. And so there's a study called Irungu et al. In 2013, where over 300 patients were vaccinated, HIV-positive patients were vaccinated with the standard schedule of 20 micrograms at 0, 1, and 6 months, or 0, 3, and 6 months. And as you can see in the right-hand column in terms of response, only about 65% had S antibody levels protective against hepatitis B. And the key determinants of this was clearly the state of the immune system, so CD4 counts greater than 500 and being female. If you then go on to alternate strategies and go down to the study at the bottom, which is the Launay et al. Study in 2011. And so this was a randomized controlled trial of standard dose vaccine compared to double dose vaccine, either at 3 or 4 doses. And as you can see, if you doubled the dose of vaccine at 40 micrograms and you increase the schedule so that you give 4 doses instead of 3, you're getting over 80% protection in HIV-positive individuals. And that the key predictors of response were younger age and clearly increasing the dose to 4 doses. So many countries, at least in the context of being HIV positive, have introduced double dose vaccination schedules and increased the number of doses from 3 to 4. Next slide, please. And so this is, the WHO report on how countries have done with the 3-dose hepatitis B vaccine. And as you can see, from year on year, from the early 90s onwards, the coverage has continued to increase, and we're now over 80% of coverage globally, at least in terms of populations receiving at least 3 doses of hepatitis B vaccine. And so we have really done very well in terms of rolling out hepatitis B vaccination on a global scale. Next slide, please. And this, I have to say, not surprisingly, has resulted in a decrease in the burden of primary liver cancer from a number of different etiologies, but mostly related to hepatitis B. This is data that was just being published about a week or so ago in JAMA Oncology, which is a meta-analysis of the change in the burden of primary liver cancer by countries and regions. And as you can see, in countries in the dark blue are countries where they've seen more than a 20% decrease in their burden of hepatocellular carcinoma. And as you can see, Southeast Asia and the Western Pacific and Sub-Saharan Africa have all done very well since the introduction of their 3-dose hepatitis B vaccination schedule. And so we are clearly making a difference with the 3-dose hepatitis B vaccine schedule, at least in terms of global epidemiology of hepatocellular carcinoma, although we can do better. Next slide, please. However, there is one area that still requires a lot of work, and this is the prevention of perinatal hepatitis B transmission. In other words, transmission of hepatitis B from mother to child, or in the early neonatal period in terms of sort of horizontal familial transmission, or in early childhood, again as a result of horizontal transmission. So this is a graph at looking at progression to chronic infection once people are exposed to hepatitis B and its relationship to age. This is probably the reason why there is such a high burden of disease in sub-Saharan Africa and Southeast Asia, is because the vast majority of transmission is in the perinatal period. As you can see, if newborns are exposed to hepatitis B, then the likelihood of getting chronic hepatitis B infection is more than 90%. On the other hand, on the right-hand side, if you expose immunocompetent adults to hepatitis B infection, then less than 10% go on to develop chronic infection. It's for this reason preventing perinatal hepatitis B transmission is crucially important if we're going to have more than that little impact that we saw in hepatocellular carcinoma in the last slide. So next slide, please. And so then the next question we then need to ask ourselves is, what is the associations of risk of mother-to-child transmission of hepatitis B infection? And this is a number of studies put together, but as you can see, that the overall risk of infants of HBV DNA positive mothers is around 3% of acquiring hepatitis B infection, and then the vast majority of those will then go on to get chronic hepatitis B infection. However, if you then look at E antigen positive mothers, that risk is more than doubled. And then if you look at the maternal HBV DNA, in other words, the viral load of the mother, immaterial of their E antigen status, then having more than 10 to the power 8 copies per ml of HBV DNA, again more than doubles your risk of mother-to-child and perinatal transmission of hepatitis B. And so, next slide, please. So how do we prevent transmission of hepatitis B from mother to child? This is an example of an algorithm, and so all pregnant women must be tested for hepatitis B infection at booking in pregnancy, and then clearly in that first trimester we need to assess hepatitis B replication and liver disease for the mother, and clearly if she's in need of treatment in her own right, then that needs to happen there and then. If she doesn't need treatment in her own right, in other words, she has got low levels of HBV DNA with very little hepatic fibrosis, then you reassess quantitative HBV DNA levels at the end of the second trimester. And then based on hepatitis B viral load, you either consider giving mother treatment in that third trimester to bring the viral load down, or if the viral load is low, then you need to ensure that the infant receives vaccine at birth, in other words, within the first 24 hours of being born. If the mother has a very high viral load or is E antigen positive, etc., then not only does the infant receive vaccine at birth, but you can also give hepatitis B immunoglobulin. Next slide, please. And so this is summarized in this slide, which is looking at standards for prevention of mother-to-child transmission, at least in terms of post-exposure prophylaxis for the child. So children of E antigen positive mothers must receive hepatitis B immunoglobulin plus burst dose vaccination within 24 hours. Those mothers with very high HBV DNA levels, if they haven't been treated in the third trimester, must receive the same. Those infants who are low birth weight infants, and this is birth weight, I think less than 1.5 kilograms, also need to receive immunoglobulin and burst dose vaccine because they are not able to mount an immune response very easily. All children of HBs antigen positive mothers, if they are not in the category to receive B immunoglobulin, must receive burst dose vaccination within 24 hours. So let's go to the next slide and we'll show you what the problem with this is. And so whilst we saw coverage of the 3-dose vaccine in childhood immunization programs of almost approaching 90% in all regions of the world, this is the coverage of the burst dose vaccine in children born to Hep B antigen positive mothers. And as you can see, here is where we have a real problem in terms of preventing mother-to-child transmission of hepatitis B. The coverage is at best 40% globally, and as you can see in the red line, the coverage in Africa is abysmally less than 10% of all infants getting burst dose vaccination. And this is where our biggest problem is in terms of preventing hepatitis B infection. Next slide, please. And so, apart from vaccination of all children and adults, apart from prevention of transmission from mother to child, there is one other bit of information in terms of prevention of hepatitis B infection that we need to consider, which is the risk of hepatitis B reactivation in people who are immunocompromised. So remember that hepatitis B infection, although people can spontaneously clear infection in terms of being S antigen negative, there is little bits of CCC DNA still in the hepatocytes of most adults, and that if you immunocompromise patients enough, they may be at risk of reactivating their hepatitis B. This is looking at the risk of hepatitis B reactivation by disease that causes immunosuppression. And up in the red, you can see that those patients who had bone marrow transplantation or solid organ transplantation remain at the highest risk of hepatitis B reactivation, and so need to have prophylaxis to stop them reactivating hepatitis B. Down at the bottom in blue are less immunosuppressive conditions, at least in terms of hepatitis B reactivation, including HIV, autoimmune diseases, and inflammatory bowel diseases. There is a particular risk associated with rituximab or anti-CD20 therapy, and that increases the risk of hepatitis B reactivation. Next slide, please. So this graph then looks at HBV management in patients receiving chemotherapy or immunosuppression treatment. I really don't want to take you through this in any great detail, but just to be aware that there are strategies that one can use to stop people reactivating hepatitis B as a result of natural or iatrogenic immunosuppression. Next slide, please. And then one final thing that I wanted to cover before we finish is the use of tenofovir-based therapies in the treatment of HIV and how they may actually prevent hepatitis B reactivation or infection. So there is now a number of cohort data sets that show exactly the same thing, that if you have HIV-infected patients on tenofovir-based antiretroviral therapy regimens, then their risk of acquiring hepatitis B, immaterial of their vaccination status, is minimal. Now, please remember the same does not apply for lamivudine alone-based therapies, and so this needs to be tenofovir-based therapies. And as you can see from the graph on the right-hand side, that having HBV active treatment with tenofovir-based therapy reduced the incidence of hepatitis B in this Dutch cohort. So this is something that we need to think about in terms of our HIV infected patients for whom we've either not been able to vaccinate or not been able to test for hepatitis B, where using tenofovir-based therapies will protect both against disease progression if they are infected with Hep B, and may protect against hepatitis B infection. So final two slides. Next slide, please. And so, and next slide, please, Kirsten. So from a WHO global elimination strategy point of view, in terms of hepatitis B, the key issue is hepatitis B vaccination, at least 3 doses of vaccine for the vast majority of people living around the world. And here we're doing very well. But in terms of preventing mother-to-child transmission, the coverage of that burst dose vaccine is very, very poor, and we really need to increase that to 90% if we're going to try and achieve the WHO's global elimination strategy for hepatitis B and hepatitis C. You can also see at the bottom of this that again, HBV treatment coverage is also extremely poor at this stage, and so this is something we're going to need to do better with. Next slide, please. So I'm going to stop there, and if there are any questions, I'll be very happy to take them. Thank you very much.
Thank you very much, Sanjay. So dear participants, you can either write your questions in the question field, or for the brave ones of you, please raise your hands and I will unmute you. Sanjay, I will just read the questions that participants wrote to us before. So, question in advance. So, is HBV vaccine booster needed after 10 years if I have antibodies?
So, this is a very interesting question, and so the traditional view is that the amount of antibody in blood is related to protection, and so the classic view is that you need over 100 international units per mil of antibody quantified to give you 100% protection. There is a view that any antibody level between 10 and 100 should give you protection, and that you really don't need to boost. And so the data around this isn't great. Ideally, you should have more than 100 international units per ml of S antibody levels to give you complete protection, but levels between 10 and 100 are probably more than adequate in terms of protection. There is also a school of thought that if you are an immune competent adult and you've received at least 3 doses of vaccine, but still have undetectable S antibody levels, that you may have protection without actually seeing S antibody levels. In other words, you may have cell-mediated or T-cell immunity that will protect you against hepatitis B infection.
Thank you. Another question is, what, if any, are the potential risks of using intermittent PrEP using Truvada when not prescribed through clinics? Are there with both the prevention and treatment of HBV?
So I think intermittent Truvada as PrEP is an interesting notion. So I think the first thing we got to tackle is what is the risk in those that are chronically infected with hepatitis B. So we're all aware that if you're chronically infected with hepatitis B and you stop your hepatitis B treatment, then there's a risk of a flare, a treatment withdrawal flare of hepatitis. And then in patients with advanced liver disease, this may cause decompensation. And so this is one of the risks of taking intermittent Truvada without knowing your hepatitis B status. And so it is said that one should check for your hepatitis B status and make sure that you're S antigen negative before embarking upon intermittent PrEP with Truvada because of the risk of flares. Having said that, the EATG study did have a small proportion of patients who are Hep B S antigen positive and received intermittent Truvada as PrEP, and that there were no reported flares in that study, but this was a very small number of patients. The risk really for intermittent Truvada is for patients who have got chronic hepatitis B and advanced fibrosis where flares can be quite dangerous. So that's the important bit in terms of treatment. Now, whether Truvada as intermittent PrEP will prevent hepatitis B infection is as yet unknown. And in fact, whether Truvada as daily PrEP will prevent hepatitis B infection is very likely, but we have no data supporting this apart from the cohort studies I showed you in HIV positive patients who took Truvada for their treatment.
Okay, thank you very much. I do not see any other questions nor raise hands. So I would suggest to move to the topic of hepatitis C prevention with Ricardo Fuertes.
Hi, Christian. Thank you for the invitation to be a panelist in this webinar. I'm Ricardo Fuertes. I work for a patient organization, GAT, and I'm currently the director of a harm reduction center in Lisbon. And so I will focus the presentation in prevention of hepatitis C among people who inject drugs, because I will use mainly some of the ideas and experience that we have experienced locally with local communities. Next slide, please. Yes. So I'll briefly mention some things related to prevalence among general population and key groups. Then I'll describe key interventions to prevent Hep C among people who inject drugs. And then I'll explore a bit more treatment as prevention for hepatitis C. That is something that is probably yet not so much discussed. And then barriers in access to treatment, talking about the project that we did in our harm reduction center, Reach and Link. And then a brief mention to Hep C activism also. So next slide, please. So as we can see, this is an image of prevalence of Hep C among general population in Europe. There are differences. There are also many gaps. As an infection that is asymptomatic, many people don't know that they have Hep C or that they might have been at risk. So it's transmitted by blood to blood. And many of those who live with Hep C might not be aware of living with it. So these data are not so accurate. There are a lot of data missing. And sometimes the data reflects more testing strategy, reality itself. And this is also true not only for general population, but for some of the key groups, like people in prisons, some communities of migrants, some MSM as well. But next slide, please. What we have no doubt is that people who inject drugs are the key group for hepatitis C. There are also regional differences, but for example, in Portugal, those who have a history of injecting drugs, well, 80% of them live with hepatitis C, so huge numbers. And for those who use drugs and those who work in the drugs field in Portugal, for example, like it's my case, that this brings us many issues, how to prevent Hep C in with such prevalence, high prevalence. Next slide, please. And I will describe the main interventions to prevent, primary interventions to prevent hepatitis C, especially for those using heroin, would be to provide needles and also opioid substitution treatment. This is quite obvious. If we provide clean equipment to inject, this will reduce the need to share equipment. And also, if there is opioid substitution treatment available, this will lead to less injection of heroin and also less need to inject sometimes in desperate situations facing withdrawal symptoms, for example. So I also want to mention that these interventions are not useful only to prevent HCV, but are also a point of contact with services that are key to prevent overdose deaths. So their usefulness goes beyond the prevention of infections. Next slide, please. But although the evidence of needle and syringe programs and opioid substitution treatment combined, it's more evident for preventing new HIV infections. There is it's more limited. There is limited evidence that this impact is the same for HCV, and sometimes it's also difficult to isolate the impact of these interventions. Next slide, please. And I will use a new review, a Cochrane review, that has explored the combination of opioid substitution treatment and needle and syringe programs. And it indicates that opioid substitution treatment is associated with an average 50% reduction in the risk of new HCV infections in people who inject drugs, combined with high coverage of needle and syringe programs, achieves a reduction on HCV infections by 74%. Alone, high coverage of needle and syringe programs there is weaker evidence of its efficacy for HCV new infections. So there are still some gaps. We need to explore more how the coverage of needle and syringe programs has impacts on HCV. So that's next slide, please. We have still in the field a big work to do to remove restrictions to opioid substitution treatment and needle and syringe programs to really achieve a reduction in HCV transmission. We need to develop gender-sensitive policies to make these programs more effective with women who inject drugs. It's also important to provide adequate dosages of methadone and not to provide less than what people need. That sometimes happens. And we need to provide needle and syringe programs combined with access to opioid substitution treatment. And I would say that's the practice in many settings. But this somehow limited efficacy of this leads us to think what else can we use? How can we combine the interventions that we have with some new possibilities? And that's next slide, please. When treatment as prevention comes, and treatment as prevention has been discussed for some years now for HIV. Until now, we didn't discuss so much treatment as prevention for hepatitis C because interferon-based treatments were not so effective and had many side effects, so it limited the way how we could scale up treatment. But now with interferon-free direct-acting agents, we can really scale up treatment, reach more people, and have impact also in transmission. And I will mention some of the things that are described in the literature, but are also in our minds in the field. So if we really want to have an impact not only in individual health, but in prevention, we really need to substantially scale up treatment regardless of fibrosis level. And here costs of treatment are really a challenge. We have to overcome this. And we also need to take account of the injecting partnership network structure. What does it mean? So in real life, people inject drugs with others, with partners, in certain settings with higher prevalence. And we need to strategize the way how we start treatment. For example, if somebody will start treatment, taking account that this person might use drugs with another person who might be Hep C also infected, and we could start treatment at the same time. This kind of strategies, I think, are not considered, as far as I know. At least not so. It's not so common to see this approach, and we could really have a strategy to treat people and try to combine treatment among groups of people who use drugs together, or in the same prison setting, or in the same neighborhood. This kind of approach, I think it will be useful to take in account. Next slide, please. And of course, there are numerous sources to get Hep C treatment among people who inject drugs, especially those who are more vulnerable. This is well, something that we all see from our daily work. This has been also mentioned by the International Network of People Who Use Drugs, and we really need to address the barriers. Otherwise, we will be treating those, especially who are not using drugs now, who might have better social context, more support, and we will leave behind many people who inject drugs, and this will enable us to eliminate Hep C and eliminate transmission. Next slide, please. We also had the needs in our project in Lisbon to understand who was having access to Hep C treatment. So we have now in Portugal an increased access to DAAs, but for us was not so clear if those who are more vulnerable were having access or not. And so we did a research project with support of EATG and Gilead Europe. And it's a peer-led project, so peers helped to design the interview and did the interviews and additional tests. We interviewed, 49 people with Hep C, and we selected 46 had eligibility criteria to be included in the study. They are mostly people who use drugs or have used drugs in the past, but as you see, 85% are currently still using drugs, either injecting or smoking. And many of the participants live with HIV, 37% live with HIV for more than 20 years. And we've explored if they were having access to treatment, and if not, why not? So let's see the cascade. Next slide, please. And this is what we found. Among participants, 85% were offered referral, 76% went to a specialized medical appointment, taking account that in Portugal, Hep C treatments are only provided in specialized clinics in hospitals. And here there's the big gap. So only 33% were offered treatment. So here we will explore a bit more. There's a big gap among those who have finally reached a specialized treatment, but those who have stayed time enough and with a strong connection with their healthcare provider in order to be offered treatment. And in the end, only 11% until now concluded treatment with success. And now, next slide, I'll explore a bit more. Yeah, next slide, please. Yeah. So some of the barriers described in the interviews, barriers for accessing specialized health services, were, well, living conditions, bureaucratic problems, discrimination, also lack of information. And this is also key, many participants described a devaluation of seriousness from health professionals. Let's say health professionals in primary healthcare settings, treatment centers, prisons, were almost actively not considering that having a specialized appointment with a specialist would be important. So many of the participants delayed looking for specialized treatment for Hep C. So here is a big responsibility also from health care providers. Next slide, please. And usually we think about access to health before really arriving to the hospital. So the big effort to reach clients, to reach people who use drugs to hospitals, but also inside specialized health services, there are barriers that need to be addressed. And some of them are related, again, with bad living conditions, with drug use that sometimes makes it less a priority to take care of health, but also bad relationship with doctor, lack of information. And we see this many times, delaying treatment. So having to go many times to medical appointments before being suggested treatment, and this is lived with frustration and motivation vanishes throughout the process. And next slide, please. Yes. So we'll present this project in Addictions Conference in a couple of weeks, and we'll try to write and disseminate a bit more the results. I will also like to mention the role of Hep C activism. We believe that we cannot alone. It's important to create the conditions for people to associate, to do bigger changes, and that's, I think, the only way to achieve more structural changes. And I will describe Hep C activism in Portugal in the last couple of years as an example that might inspire others. So we have an estimation of 50,000 to 100,000 in Portugal. It's not yet clear, but what we know for sure is that there is a high prevalence in people who injected drugs. Until, well, in 2014, there was at least one new DAA ready to arrive to the market, but negotiations between government and pharma seemed inconclusive. Many people were waiting for the arrival of new treatment, but this seemed not to arrive. And next slide, please. And the community started to organize, patient organizations, but also people who use drugs started to organize and demand for sustainable costs of the new treatments. Also, the demand to not leave no one behind, so include also people in prisons, people who use drugs, and documented migrants, and compassionate access programs to ensure access to treatment options until the completion of negotiations. And next slide, please. In early 2015, it was possible to reach an agreement between one of the pharma companies and the government. And some of the key points of the agreement were same price for 3 months or 6 months treatment courses, payment per patient treated. Also, so the government will only pay if treatment is successful, and the price of each treatment becomes lower if more people are treated, and also centralized funding program for hepatitis C, so that hospitals don't use this funding to other things. And this was a big change in Portugal. So now more people are having access to treatment only with DAAs. So what is said, oral for all. We are not doing any more interferon-based treatments. And next slide, please. What I would like to really stress that this was only achieved because patients mobilized, created pressure, used strategically the media, met with all relevant stakeholders, and what I think it's really key was that people who use drugs actively took part in this negotiation, and did pressure publicly. I saw many of our clients disclosing for the first time publicly their Hep C status because they thought this is a fight worth to fight. So this was key, and I think activism really is important to achieve structural changes. And it's important not only to achieve access to treatment, but also to use it also as prevention. Next slide, please. So some conclusions. Traditional prevention tools, like I said, needle and syringe programs and opioid substitution treatment alone are not enough to eliminate HCV transmission. HCV treatment as prevention can become a major game changer in the next years, but we need to strategize more, not only to overcome costs, which are a big barrier, but also we need to strategize how and when to do treatment and how to address the barriers to treatment. And here we need a tailored approach with local communities and to know the community well and overcome the barriers that exist. And also participation and meaningful involvement of people who inject drugs really makes a big difference. If today there are no questions, you can always approach me by email. Thank you.
Thank you very much, Ricardo. If you have questions today, just write them in the question field or raise your hands. Here you can see again where to click, where to write your questions. Ricardo, I have one question. You mentioned that even if when patients or when your clients come to get medical appointments, even if they go to hospitals and meet doctors, there seems to be a strategy from the hospital side to delay the start of treatment. So it's not prescribed immediately, but there's one appointment, another appointment, another appointment. Yes. Has there been some dialogue with doctors on this? What are your plans or plans of your organization in terms of advocacy towards it? And what is the reason behind, if there is such a strategy, what's the reason behind it?
Well, of course, we see different approaches in different doctors. We see some doctors that are very sensible and they understand the difficult situation of many of our clients. And the big effort to reach the appointments, well, sometimes after difficult days, being able to, to get motivated to go to the hospital and have the appointment, and they do the effort to try to simplify the process as much as they can, and they also ask for our support to make it as simple as possible, let's say. But we also see, some other hospitals really delaying treatment. Sometimes the clients go 7-8 times to different appointments, and they still have no clue if they will be able to do treatment, and that's very disappointing. People lose motivation because, of course, especially when life is very complicated, it's difficult to find time and even financial resources to go to the hospital. So when they see that treatment is not arriving, so in many occasions they give up. We've been calling attention to this problem, meeting regularly with doctors. We are suggesting to simplify treatment, to decentralize some of the procedures, to bring them to the community. That is very difficult. I think healthcare is very, not so flexible. All changes are difficult. So we see that, I think in the next in the next years we will not see so many changes in bringing to the community, to harm reduction centers or treatment centers, some of the procedure, blood tests, FibroScan, etc. But we are trying. This project, Reach and Link, that I've mentioned, that was done with support of EATG, will also help to create some awareness on this problem. and we will present it in several conferences, and hopefully this also will have an impact.
Is there some data on how long it, on the average, takes to, like, how many appointments a patient has to have until he gets treatment on the average?
Well, I don't have now this information. What I can tell you is that only a very minority, as you've seen, arrives to get treatment, and most of people have had appointments before, but in the process stops going to the hospital, for example. I have the information that some colleagues gave me that in some hospitals, after 8-9 appointments, treatment is still not offered. So yeah, there's a problem there, but I cannot tell you accurately how many appointments are needed.
Another question, it's a bit of a different topic. So how are we going to prevent HCV transmission by chemsex intravenous drug use? What are the approaches there?
Well, it's a completely different area. I have some contact with MSM projects, but we are not focusing so much in Lisbon for the moment in that, so I would not feel comfortable in providing an answer on that. We are not in Portugal for the moment seeing MSM using injected drugs for sex, so this is something that other people might answer, not me.
Okay, thank you. I do not see any more questions in my list. So I would like to thank you both, Sanjay and Ricardo, for your time and for your efforts and for your very interesting presentations. Thank you, dear participants, for your interest in the topic, and I'm sure you can contact the speakers if some additional questions arise later on. We will also upload the recording, edit and upload the recording, and I will share with you the link so that you can watch it over and over again or share the recording links with your colleagues. Thank you very much, and I wish you a very good day.
Thank you very much. Goodbye.
Thank you.